Hello, my name is Dr. Amanda Walker from Albany Medical College, and I will be presenting a study entitled Endoscopic Gastrojejunostomy Revision Following Roux-En-Y Gastric Bypass Leads to Effective Resolution of Dumping Up to 3 years Postoperatively. Thank you for the opportunity to present our work. None of the authors have any disclosures. Dumping syndrome is one common long-term complication after Roux-En-Y gastric bypass that can negatively impact health-related quality of life. The reported incidence of dumping is as high as 20 to 50% and can be classified as severe in 11% of patients experiencing symptoms. Early dumping, which is seen more frequently than late dumping after Roux-En-Y gastric bypass, typically occurs within 1 hour postprandially and is secondary to the rapid transit of food into the small intestines, triggering a fluid shift into the intestinal lumen that results in nausea, vomiting, palpitations, diarrhea, warmth, and flushing. Dumping syndrome is initially treated with dietary and lifestyle modifications. However, dumping syndrome that is refractory to dietary changes may be due to an anatomic cause, dilation of the gastrojejunal anastomosis. In such cases, anastomotic outlet reduction can slow gastric emptying, improving dumping symptoms and patient quality of life. Endoscopic gastrojejunostomy revision, or EGJR, is a safe, effective, and less invasive alternative to conventional laparoscopic revision. The Apollo overstitch device allows for full thickness endoscopic plication and can be used for endoscopic management of dilated gastrojejunal anastomoses. Several studies have demonstrated that EGJR correlates with improvement or complete resolution of dumping within 1 year post-procedure and also impacts weight loss. However, in this study, we aim to determine the durability of resolution of dumping syndrome after EGJR at a mean of 3 years. The surgical approach using the Apollo overstitch device is as follows. First, the gastrojejunal anastomosis dilation is confirmed with the diagnostic endoscope. Next, the circumference of the anastomosis is coagulated with hot biopsy forceps. The Apollo overtube is then placed and a therapeutic scope with the overstitch device is inserted. Figure of 8 or interrupted sutures are serially placed. The endoscopic cinching device is then deployed to secure the suture. Lastly, at completion of suturing, a diagnostic scope is reinserted to ensure that the diameter of the lumen is not overly constricted. The methods used in this study involved electronic medical record review for patient demographics, comorbidities, smoking status, and pre- and post-operative dumping symptoms, as well as weight at various time points. A total of 98 patients received EGJR for dumping syndrome from January 1st, 2013 to December 1st, 2018 at our institution. The primary outcome measure was resolution of dumping after EGJR at 1 month and long-term follow-up. Statistical analysis of our data included univariate analysis, Fisher's test, and 2 sample student t-tests with equal variances. The vast majority of patients included in our study were female at 97% and Caucasian at 85%. The mean age at the time of EGJR was 51. The average BMI at the time of revision was 36. GERD was the most common comorbidity seen in 59% of patients. EGJR was performed at an average of 8.4 years after initial bypass surgery. The average length of stay was 1.3 days. The procedure time was calculated to average 72.3 minutes. This calculation for procedure time included only 59 out of 98 patients due to a change in the medical record system during 2013. Additionally, 13 patients had a concurrent procedure performed, such as an incisional hernia repair or cholecystectomy, and were therefore not included in this calculation. Complications were minimal. There was 1 esophageal mucosal injury that was repaired intraoperatively and did not impact this patient postoperatively. Within 30 days postoperatively, there were 5 emergency room visits, 2 for melanoma, 1 for UTI, 1 for abdominal pain and bloating, and 1 for headaches. 3 of those 5 patients were readmitted to the hospital, the 2 with a GI bleed and the patient with abdominal pain. Of the 2 patients with a postoperative bleed, 1 was on postoperative anticoagulation for a prior clot that did improve with conservative management, and 1 required an endoscopy, though no active bleeding was found. Beyond 30 days postoperatively, complications included ulcers, 2 at the anastomosis and 2 with classic marginal ulcers, as well as GERD reported in 2 patients. Of the 98 patients undergoing EGJR, 69 of them had initial bypasses performed at our institution from the late 1980s until 2016, with most, around 65%, performed laparoscopically. At 1 month post-revision, 100% of patients were evaluated in a follow-up appointment. At that time, 88% reported complete resolution of their dumping symptoms. 7 of the patients with initial resolution had recurrent symptoms and went on to require a repeat EGJR at an average of 2 years after the initial revision. These repeat revisions were effective at resolving dumping at long-term follow-up for each of the 7 patients. 64 of the initial patients completed long-term follow-up at an average of 3 years after initial EGJR. 84% of these patients who had long-term follow-up had persistent resolution of dumping. 10 patients, 16%, had recurrent or persistent symptoms. Interestingly, 47% of patients with preoperative comorbidity of GERD experienced dumping resolution at long-term follow-up. Patients with the preoperative GERD had a statistically significant improvement in dumping with a p-value of 0.036 compared to those without GERD. Roux-En-Y gastric bypass is widely recognized as an effective therapy for GERD when there is underlying morbid obesity. After initial Roux-En-Y gastric bypass, GERD symptoms are suspected to be due to an anatomic cause, such as a hiatal hernia, an enlarged gastric pouch, or an enlarged gastrojejunal anastomosis. However, symptomatology is subjective. Further studies using more objective criteria, such as pH manometry, is warranted to attribute symptoms to GERD. In addition, it is possible that some of the GERD symptoms reported by patients have been due to maladaptive eating behaviors that were then addressed by a comprehensive dietary counseling during the perioperative phase for revision. It would add further insight to study the relationship between GERD and dumping if a validated health-related quality of life survey were used, as both symptoms of GERD and dumping can be quite subjective. Weight loss was also tracked over time as a secondary outcome. Weight loss was statistically significant at 1 month with an average of 9 pounds lost. Given the broad distribution or standard deviation of weight loss at long-term follow-up, it is likely that some patients have greater benefit than others from EGJR for weight recidivism. In conclusion, EGJR is an effective, durable, and less invasive option for patients with medically refractive dumping syndrome. However, our data does not support the use of EGJR for weight loss. The presence of GERD preoperatively correlated with a statistically significant improvement in dumping symptom resolution, and additional studies using techniques for confirmation of GERD would clarify the reproducibility of this result. Further study in a randomized controlled fashion using validated scoring systems for dumping symptoms are necessary to further validate our long-term findings. Thank you.